Okay, good evening, everyone. My name is Letitia Lebrecq, and I'm the Executive Director for our affiliate, NAMI Valley of the Sun. And I just wanted to share a couple things with you of how we landed on this topic and this very important topic. Our affiliate was chosen as one of the agencies to help educate individuals on tardive dyskinesia, some of the elements surrounding it, some of the stigma surrounding it, and kind of up-to-date information for those of you who have loved ones or you yourself have experienced the side effects of tardive dyskinesia. So we're very proud to be a part of this educational series. And we were awarded a small grant from NAMI National to bring this education to you tonight. This event is being recorded and we will have it on our website, and we'll post it for anybody who was not able to make it this evening, or you know of other loved ones that may get some good information and you want to share it with them. We'll have that available to all of you. So yes, I am very proud to bring you tonight's educational series, and Leanne was able to find us a great speaker by the name of Melinda, and I'll turn it over to you, Leanne, to introduce Melinda.
Thank you all for joining us. I echo everything Letitia said. We're thrilled that everybody's here tonight. I was shocked myself when I started doing some research and trying to find somebody, that the world of tardive dyskinesia is smaller than I anticipated. In the world of internet, where you can search just about anything, it was difficult to find a professional. So Melinda claims that there's not much interesting about her, but I disagree. And I think she has some fabulous facts to share with us tonight. So without further ado, this is Melinda Claypool, a certified nurse practitioner, a psychiatric nurse practitioner. Thank you, Melinda.
I'm both. I'm certified and psychiatric, so that works. Hello, everyone. I have never shared screen before, so I apologize. We are going to see how this goes. Okay. Hopefully you can see that.
Perfect.
So, tardive dyskinesia. It is something that is not widely talked about, but it affects a huge quality of life for the people that do deal with it. So, basically, this is something that is medication induced. Okay, this doesn't just happen. You don't just get it. It comes from taking something. So obviously, where NAMI is involved, that is usually psych meds. There are a few other medications out there in the world that can cause it. The big one is Reglan, so you see the GI disorders. But primarily what we see this is the mental health stuff. So you can see a few there: Zyprexa, Seroquel, Abilify. There is a theme in this. It is the antipsychotic category of medications. So, it's not your antidepressants. It's not your anxiety medications typically. It is the class that the FDA says is antipsychotic. And what that means is it affects a certain chemical in the brain, the dopamine. So when we look at tardive dyskinesia, what does it actually look like for a person? For the loved one that you're seeing go through something and you don't know what it is. It's considered a neurological disorder, but again, it's that drug-induced. So it is involuntary movements, okay? So a lot of people are like, oh, they have Parkinson's. It's not Parkinson's. They can't control it. A lot of times it starts in the face, the mouth, the lips, the tongue. I have a lot of clients that tell me that it actually starts, as what we call extrapyramidal side effects, EPS, where it's a pain, and then suddenly we take them off their meds or switch their meds, and it hasn't gone away. So that's when we move from it's a side effect to it's a permanent syndrome, a permanent effect. As you can see, these pictures here, it's not pleasant. It's not comfortable a lot of times. And, this gets you looked at in a different way when you can't control your tongue, you can't control your lips. And people, give that label. So, you see someone walking down the street doing this, it's gonna get them judged, and it's not a good thing. It can get to the point where it's not just some tongue movement, it actually is coming out of their mouth. It is moving around on its own. So this is as it progresses. It actually can get worse, as if it's not already bad enough when it starts. The whole face can actually be involved. I've seen people do the puffing out of their cheeks, the chewing movement. Like people are like, oh, I'm just chewing gum. There's no gum in there. They are making these unusual facial expressions, like the grimacing. They can't control it. So it looks like, oh, well, maybe they have, I don't know, Tourette's or something. No, it's literally they have no control, and it's from the meds. So it's can be quite embarrassing. So if your mouth is involved, what happens? You can't talk right. You can't necessarily eat right. I've had people that say, I don't go to restaurants because my tongue actually thrusts the food out. So I want to be at home. I don't want to be in public. I don't want people to be watching me do this. So it's affecting their life. What if, you go to swallow and suddenly your throat spasms and whoops, it didn't go down. So it makes everyday life difficult. So typically it starts in the face. However, the brain, of course, decides that it can go other places. Usually we see it in the hands, but you can see in B and R, I guess. I don't think this is an American photo here, that the hands can really clench and tighten and move where they can't control it. But at the same time, it can affect your shoulders, your hips, and your feet. So they can be sitting there wiggling in the chair, their hips are moving back and forth, and everybody's like, oh, they're just anxious. No, it's, in this case, it's not anxiety. And when we talk about the legs, people usually think bouncing of the legs or shifting. Well, I've heard of a very scary example that there was a diabetic patient who had developed tardive dyskinesia, and the issue was they were curling their toes. They could not control this. And if you know anyone with diabetes, if they have neuropathy, they can't feel their feet. So not only are they doing this and not knowing it, if they're not doing normal foot checks, then they can get ulcers and lacerations and things. And because of the diabetes, they don't feel it, and then they don't heal as quickly either. So it can cause a lot of medical problems on top of it. So this is a spectrum, just like everything else. It can be mild to, oh, my tongue is just kind of doing a little bit, or, I can't control my mouth movement completely, to completely debilitating. So, it does get worse if we don't adjust the meds, do something, someone catches it and actually cares. I have had patients that I clearly look at them, and when I test them, they have tardive dyskinesia, and I say, okay, well, how much is this bothering you? It's not bothering me. Do you know it's happening? Yeah, I don't care. It's their choice. However, if you have someone with a severe mental illness, they might be used to being like, oh, this is fine. It's not a big issue. So they just accept it. If you have someone who's not, their illness isn't under control. What's worse? The voice is telling me to kill myself, or the fact that I can't control my mouth. So that also obviously takes a toll and has an impact on their decision making of what they need to prioritize. So let's say you have someone with a severe mental illness that's been on meds their whole life. They live to a good ripe old age, and suddenly they have dementia. Again, are they going to even recognize it's a problem? So it's definitely something that is perceived both by the patient and by the people around them. And sometimes the caregivers or friends or family or whoever it is needs to step up and say, this is something that's going on. And is there something we can do? Does this have to be permanent? Do they have to live like this? Because if no one speaks up for some of these people, nothing happens. Nothing happens. Most of my patients that I have treated for this, they just thought it was life. I have to live like this. There is no help. And unfortunately, until recently, there really wasn't help. But now there are some options. So you don't have to live like this. They don't have to live like this. Your loved ones don't have to live like this. Usually it is long-term medication management, usually, okay? So people say, oh, they were started on, the really nasty antipsychotics back in the day, back in the 60s, the 70s, the 80s, it took years to develop this. Doesn't have to. It can be over the course of months to the first year of treatment. It can be as little as 6 weeks. Everyone says, oh, this is a person for, who is older, and they're in their 50s or 60s. It's not a big deal if they have this. I have treated a 17-year-old for tardive dyskinesia. It still happens. New cases still occur, and it does not matter the age. What matters is the medications that they were on and potentially for how long. And of course, dose also can affect things. So a lot of people brush it off. They haven't been on meds long enough. They probably have. So the way we used to treat this is we took them off their meds. That's not always a good option. And sometimes we can. Sometimes we can lower the dose. However, when we look back, this wreaks all kinds of different havoc. Symptoms come back. The voices or what they're seeing, they get terrified and they go out of treatment. I don't blame them. I wouldn't want to feel like that either. It wasn't really helpful taking them off their meds because once the symptoms have started, they generally don't stop, even if we stop the meds. They might go down a little, but the symptoms are still there. So this is a bad practice, was a bad practice, and still is. A lot of people still take this approach. Either it's, they're fine, or, oh, we'll just stop their meds. That's not good options, either one of them. So what do we use to treat these? What do we use these meds for? Everyone thinks the psychotic disorders, schizophrenia being the largest of those that people think of. However, we can use these meds for almost anything. It's a very common medication for patients with bipolar, patients with depression. We add antipsychotics all the time to assist their antidepressant. PTSD. We can use anything to treat PTSD. I use antipsychotics, I use mood stabilizers, I use antidepressants. You can use these meds for a lot of things. Anxiety. There are a few that are really good for anxiety, depending on the patient. Personality disorders. Again, there's no one thing to treat some of this stuff with. So any mental health patient, for the most part, could have the potential exposure to an antipsychotic. So that's a lot of people that can be put at risk. Because if you think about it, we try to have a medication trial last 1 to 3 months minimum. So that puts them in the 6-week window. So here we go to this old style of treatment. We take them off their meds. What happens? Well, symptoms come back, potentially. If you're acting weird, your employer doesn't want to keep you on. So you lose your job. Now you have no income. So then you get evicted. Now you're evicted and homeless. So your family's like, oh, we've been through this cycle before, lose friends, lose family. If you're sick, you're not taking care of your physical health. I've seen it so many times that I get them stable and they're like, oh, I feel great. wait, why do I have diabetes and high cholesterol and high blood pressure and I have seizures? I didn't have all this before. They did, they just didn't know it. So every time we have a relapse of symptoms, physical health declines as well. And of course, we have the chance of mental health with drug use. It is higher in the mental health population, just like mental health is higher in the drug and addiction population. They go hand in hand for a lot of people. Not everyone, of course, but if you've got nothing else, it's a possibility. So now what do we do for them? Take them off their meds? So we can't take them off their meds. Maybe we can't even reduce the dosages. We now have an option. We used to treat this just like it was EPS, cogentine, artane, Benadryl, but it doesn't treat TD, not at all. Can it block EPS? Potentially, but not always. And it does not affect TD, not at all. So why is this so important? Like I said, we can use antipsychotics for any number of diagnoses. Here's the list of every antipsychotic that I could think of on the market in the US, and then those few that are not antipsychotics. That's a lot of meds. When it comes to mental health, this is a long list. And I have seen this from Reglan. So the bigger risk category is the first generations, but I still have a lot of people that take these. The one that's notorious for this is prisons. The prisons love, for some reason, they love putting people on profenazine and haloperidol. I see even young people coming out on these meds. I see it even in the private sector. They say when they marketed the second generation, they market it as you can't get tardive dyskinesia. That's a lie. All the pharma companies are lying about that. Any of these drug reps can come in and go, oh, you can't get TD from my med. Yes, you can. It is a lower chance. It is lower, much lower. However, if you've ever been on the first generation, it skyrockets your risk. It doesn't matter that you're not on it anymore. It doesn't matter that it was 20 years ago. If you've been on it, it raises your risk factor, even if you've been on the second generation for a very long time. So the difference between them, everyone says, oh, it's Parkinson's. No, it's not. There is a slight fine hand tremor with tardive dyskinesia maybe in the beginning, but it doesn't last. It usually becomes pretty noticeable pretty quick and it is not fine anymore. So movement disorder, yes, please go to a movement disorder clinic. Please go to a neurologist if you don't feel comfortable with your psychiatrist. That is fine. Movement disorder clinics, they're the experts in movement. But everything else is that uncontrolled movement in tardive dyskinesia, whereas it's balance and coordination and the inability to move in Parkinson's. These are very different types of diseases. So who does this affect? 500,000 people in the US is the estimate. That's a lot of people. People without mental health are like, oh, it's fine, it's not that many. Well, that's a whole lot of quality of life in my mind. 1 in 5 people have mental health issues. And 25% of those are taking antipsychotics of some form at some point. So that number gets really big really fast. And 500,000 people with TD just in the US is still a lot, and in my opinion, still too many. So it's really important. You know. So what do we do to treat them nowadays? These two medications came on the market a couple years ago. They are related, descended from a Huntington's chorea medication. It's the tetrabenazine. If you know anyone with Huntington's chorea, that was kind of one of the big treatments for it for a long time. However, it had pretty nasty side effects. You had to dose it like 3 and 4 times a day, and it made people really tired. And so a lot of people with Huntington's chorea didn't like it, even though it worked, because then you're sleeping through your life. So then they finally started looking and saying, well, if it works for one movement disorder, could it work for others? So they took the molecule back into the lab, and 2 different companies came up with 2 different alternatives. Ingrezza is a once-a-day dosing option that a lot of people like because it's once a day. There are 2 doses. So if the low one doesn't work, the high one probably will. I have seen people on this, and I have had people almost crying because of how much it helps. There is a chance that it could make them sleepy. It does have some anticholinergic properties, so falling, lightheaded, headache, stuff like that. Stuff with the stomach, because every psych med does something with your stomach. The ones to watch out for is if it starts becoming a Parkinson's type movement, and QT prolongation is something with the heart, which is very easily tested. It's an EKG. We hook you up to electrodes. It's not invasive. Option 2, Austedo. This one is twice a day. However, there is a much bigger window of dosing. I have had patients on this. They loved it. Pretty similar side effects because it comes from the same molecule originally. Somnolence, look, stomach stuff, diarrhea, dry mouth, fatigue, and again, that same watch for the Parkinson symptoms and that same issue with the heart, the QT prolongation. So these are both wonderful, wonderful medications. I have had patients on both. They loved both of them. They stopped moving. Depending on the severity, the movements can stop completely, or at least be manageable, because I used to move all the time. I couldn't pick up a fork. I couldn't have a conversation with a stranger because of how they were judging me because of what my face did. And now it's just a little twitch in my hand or the occasional, puffing out of my cheeks or a grimace. But it's occasional, and it's really occasional. I can sit still and I can feel and look normal because now I can control my body. It does work. Obviously, nothing's going to work for everyone, but I have seen amazing things. And the people that talk about it, once they've had the tardive dyskinesia and then they've had one of these medications, hope is what it sounds like, because they have that part of their life back. They already had to fight to get it back from their mental illness, and then their body started fighting with them. So now they have that back too. And it's amazing to see it happen. It is fabulous. I want to cry with them when it happens, because it's life-changing. So.
All right, thank you, Melinda. Are there questions from the audience?
I have a question. Along with their antipsychotics, then, do they take these new medications so that they don't have these effects? Okay, so
Yes.
their antipsychotics are prescribed, and they take that and then they either do a once-a-day dosing or a twice-a-day dosing. And do they have to stay on these medications then forever?
That is still something we're trying to figure out. They
Okay.
are researching it, certainly. When they did the initial research to get it approved through the FDA, they saw that symptoms came back within a couple weeks, couple months after discontinuing, from the FDA trial. I have had one client that went off of it. And at the time, I didn't get to follow with them like long term, but at the time they were saying that the symptoms were gone. This is also a replacement. So like if they're on cogentine, benzotropine, that's the most common nowadays. They don't stay on that. So everyone's like, oh, good, more pills. Just what we all want, right? But this replaces that. It's not working. There's no reason to take something that's not working. So they stay on their antipsychotic, and then we add this, and typically it's replacing the benzotropine. And right now the indication, is to keep them on it. But they can always choose to go off and see if the movements come back. It's just from practice of what we've seen so far, the movements do tend to come back. So it is, of course, individualized, but so far it's not been out long enough to know, oh, it's 5 years, it's 10 years, it's whatever. But what we've seen so far is, yeah, they have to stay on it.
And how old is the patient? I mean, like, do they start like when they're teenagers if they need it? Or do you find that tardive dyskinesia starts if the person is older, or doesn't that matter? Age doesn't matter.
It's more about the medication, how long they've been on it.
Okay.
There are some factors. A lot of it is dose dependent. Let's see, where was that? But it's more about the medication. So like the 17-year-old that I had, she had been on antipsychotics since she was like 10 or 12 or something. She was very ill. She was very aware of her symptoms, and she was very willing to try different things.
Okay.
So is it common for a teenager to develop tardive dyskinesia? No, because most of them are not on the heavy drugs. They might be on 2 milligrams of Abilify or a quarter or a half a milligram of Risperdal. Those are not typically the patients that are going to be developing this. This is the 8 milligrams of Risperdal. This is the 20 to 30 milligrams of Zyprexa. This is I've been on 40 milligrams of Haldol for 40 years. So it's not just age. It's, got a lot of factors to it. But usually it's dose and how long they've been on it. Yeah.
Can the meds be prescribed for somebody under the age of 18?
They are FDA approved for 18 and up. However, anyone that has ever, worked with a mental health prescriber knows we do things a little differently. So I did get it approved for the 17-year-old. So can we do it? Yes. Does the federal government say we should do it? No. But a lot of things are used what we call off-label in mental health, and that's why her insurance agreed that she could have the medication. So.
And there's a couple other questions in chat. Are these meds generally covered by insurance or allowable by Medicaid?
So actually, I think all my patients have been Medicaid that I have gotten it approved for. It is a little odd. 20 years ago, private insurance was the best to have. Now Medicaid is much easier to work with than private. So yes, insurance can cover it. There are requirements. We have to do a prior authorization every single time because these are very expensive. But every time I have prescribed it, I have gotten it approved.
Okay.
So yes, it can be approved. And I'm sure you can get it for private insurance. I'm sure you can get it for Medicare. It's just those are somewhat more hoops, somewhat more difficult to work with at times, depending on the situation. So the prescriber that is working with the patient needs to know what they need to do to get this approved. It is very cut and dry what you have to do. There's a certain scale that we do to rate how severe the movements are. It's in the office. It's non-invasive. It's just having you do a few things and we score it. And the fact if they've been on something previously, mostly the cogentine, the benzotropine, but Artane counts, Benadryl counts. Strangely enough, Ativan and Xanax and the benzos count. I'm not really sure why, but they do. So as long as they've been on something before, yeah, it can get approved.
Fantastic. The next one is, how long does it take for the meds to begin working? Are they 100% effective, and is dosing escalated, or do you start with a typical dose?
You always start with a typical dose, the lowest dose of either the Ingrezza or the Austedo, and you titrate up to what is necessary. Patients, I mean, in mental health, everything's a month, but patients have told me that usually they notice a difference quite quickly, days to weeks. So is there a buildup? Yes. Is it guaranteed 100% to work? No. I can tell you every patient I've had on it, it has helped. Like I say, it doesn't necessarily make the movements zero. Again, that kind of depends on severity and the person. But the patients I have seen, both in person and the training videos that they give us as prescribers and things like that, the patients were ecstatic, even if it wasn't at zero movement, because it was such an improvement and they could cope with it at that point. So could it fail? Yes, because anything can fail. However, it has a very, very good success rate at reducing the movements. And like I say, I've personally seen it go to no movements. But again, those were less severe cases. So the more severe the case, the more work it has to do and the chance that some movements will continue.
Okay. How are these meds different from cogentine?
Cogentine is quickly becoming the bane of my existence. Cogentine does not do this. Cogentine is meant to treat extrapyramidal side effects, those EPS, the movements that are temporary. So if you stop your antipsychotic, the movements go away. That's EPS. Tardive dyskinesia is permanent. It is at that point a permanent neurological condition. Cogentine is actually what we call an anticholinergic, and we're now finding that there are long-term effects to long-term cogentine and benzotropine usage that are generally reversible, mind you, but they're not the same. No, cogentine, is used a lot for the EPS, and it does work. It totally works. I've seen it work all kinds of times, but it's not these. It's meant for EPS.
Okay.
Until these two meds came out, there was nothing that actually treated tardive dyskinesia. Complete different mechanisms of action if you go into the chemistry of it.
Can you give any recommendations on a good movement disorder clinic or a program with meds and TD treatment that somebody could call if they were interested or needed resources?
So the place to generally start, because everyone needs a referral nowadays, is your primary care provider. And I know the Mayo Clinic has a movement disorder. There are multiple neurological offices around the valley that are actually movement disorder clinics. There is also in the area, I'm not going to be able to think of his name, the boxer. Was it Muhammad Ali?
Yeah.
There's a clinic named after him in the Valley that is movement. So any good provider is going to know the movement clinics, and there are a lot of them in the Valley comparatively, only because the Valley is so big, of course. But you just need to go in and ask for a referral for a movement clinic.
Okay. Have you ever seen repetitive twisting of the head be a symptom of tardive dyskinesia?
It's potential, yes.
Okay.
Usually it's kind of a side to side or a partial twist, but anything is possible, unfortunately, when we get into the neurology of it.
Okay. And then my last question in the chat is, should TD meds be started at the first sign of TD, or do you wait?
It is best if it can be determined that it's TD, which without stopping the antipsychotic, what we do is we treat it with cogentine, Artane, Benadryl, whatever is appropriate for the patient. And if there's no effect, then it's TD. Not the best way to do this, but it's better than taking someone off their meds and having them decompensate as well. So it is better to treat it sooner, because the longer it goes, let's say the person is wonderful at taking their medications and they take their antipsychotic every day. So they develop TD at 30. At 40, they're still taking the same antipsychotic, potentially has had dose increases. It's going to get worse. So when I treated my 17-year-old, her symptoms went away completely. It was fabulous. When I have treated people in their 40s, the symptoms got a lot better, but the symptoms were also much more severe because they'd been dealing with them longer. So the worse it is, the harder it is to get back to nothing, no movement. So the sooner the better, just to try and limit the progression of the tardive dyskinesia. Yeah.
So the question is, are hand tremors TD? For example, tremors of hands when putting keys in doors or touching smartphone when the hand tremors. So I guess the question would be, can you kind of describe a little bit more in detail what the hand tremors might look like?
Hand tremors are a tricky one, because the hand tremors are more of, like, if it's a fine little movement, something like that where it's not moving much, that's not going to be TD. There are a lot of movement disorders that have tremors in them of the hand. If it's a fine motor, so doing those fine skills, trying to put a key in a door, writing with a pencil, gripping a glass. Gripping a glass can be tricky. I shouldn't have said that. It's probably not TD. I have seen people with multiple movement disorders. That was very miserable. I had someone with Parkinson's who probably also had TD. It was quite the challenge to try and manage that poor patient because they were quite miserable. One would set off the other. So there are lots of movement disorders that have a tremor, and the more fine the tremor, so those tiny fine details, it's probably not tardive dyskinesia. A tardive dyskinesia would be a severe movement, that they really can't control. So part of the testing is to check, what is the tremor in the hand? Is there a tremor in the hand? And a good practitioner should be able to tell the difference. Worst case, you go to a neurologist, you go to a movement disorder, because there are definitely a lot of movement disorders that can cause hand movements of different types.
Okay. And then I think our last question for the night is, and it's a really good one, is work being done to stop the problem before it happens? How are antipsychotic meds improving? Or are they?
They are. So they do know that if you've ever been on those first types, that first group of antipsychotics, that puts you at that higher risk. So the new ones have like I want to say it's between 5 and 10% chance of developing tardive dyskinesia, which is way better than like 40, 50, 60%, which the old ones have. But the risk is that still a lot of people use the old antipsychotics. And Sometimes you have to because maybe the new ones don't work for whatever reason. Or I've had patients that don't want to give up their antipsychotic. It works, leave me alone. Okay.
Understandably, yeah.
Yeah. So the risk is much, much larger with the old ones. The problem is it's a lifetime. So if they've ever been on it, we don't know the logic, but the research has shown if someone has ever been on those older antipsychotics, their risk shoots up. It's not quite as high as if they've only ever been on the older ones. You know, I'm not giving up my Haldol. I've been out for 50 years. Okay. But let's say worst case scenario, this happens a lot. They go to the emergency room. They're acting out, you know, because of their mental health symptoms. They give them a shot of Haldol. That counts.
Wow.
So if they have ever been exposed to those old ones, it takes their risk from that 5 to 10% to more like that 40 and 50%. So it's very scary. It's extremely scary because I see it all the time. They're like, oh, I think I was on Haldol once and I had a bad experience. Well, what were you on Haldol for? Oh, they gave it to me in the hospital. Oh, okay. So yes, it is getting better. It definitely is. However,
Definitely it's complex.
Yes, finding someone who has never, ever been exposed to those older antipsychotics is kind of a miracle. Unfortunately, I don't like the old ones. I try to avoid them, but not everyone does that, and they use it a lot of times. I still hear Haldol as the big one for that. Oh, they were out of control. Sometimes, yes, people do lose control, but not as much as they use Haldol for. No. And they do have other options as well. It's just that's the one they go to.
Melinda, do you do private practice, or do you just work in a treatment center?
Right now, I work in a treatment center and I have a small private practice. I do an online private practice. So they don't allow me to treat schizophrenia and bipolar type 1. But in my facility, I do have a lot of psychotic disorders and bipolar and other serious illness and illness that they don't claim is serious. So.
All right. Well, that concludes our. Oh, one last question. Do you think drooling can be a sign of tardive dyskinesia?
Yes.
Okay.
Yeah, because they can't swallow. They can't control their tongue, so it might even push it out. It's a possibility. Again, the whole picture is what we want to look at. But yes, it is a possibility.
Excellent. Well, thank you very much, and thank you to everyone for joining us tonight. We hope you found this informative, and definitely we will be on the lookout to get more presentations scheduled and more things to see.
Thank you. Great presentation.
Thank you, Melinda.
Thank you.
Thank you for coming.
Thank you.
Thank
Are you taking questions?
Oh.
No.
We did most of the questions. Are there still questions?
I was prescribed